Hi, good evening, everybody, and welcome to another episode of a webinar from Muscat Endoscopy Academy. My name is Samar Al-Duri, the Director of Endoscopy uh, at Medical City Hospital for Military and Security Services in Muscat, Oman. And it is my pleasure today to welcome a good friend of mine, Mr. Bassel Duwaji, who's a biomedical engineer and application specialist, and I would call him the guru of functional tests, will help us today and guide us through the jungle of how to look and assess what sometimes may seem to be chaotic results from manometries to pH monitors to impedance testing and so on. Thank you so much, Basil, for joining us, and good evening to you.
Thank you, Dr. Sami. Thank you very much for your words, and thank you for conducting this webinar.
So, first thing is first, if you can tell us quickly about yourself and what got you into this specific area or field in all of gastroenterology. It's not the most fun part, most people may think.
Yes, exactly. As you said, actually, I started working with as in the application of functional manometry since like 2004. It's around 21 years. And really, I like this application because I noticed since that time that not many people, not many staff, they like to be
Mhm.
involved in doing manometry or any functional test. Because I like it because it needs focus. You have to be focused and
Mhm.
you have to understand
Mhm.
everything. I mean, starting from the medical background about the
Mhm.
causes of like sort disorders, then preparing the patients, the symptoms of the patients, then how to do the procedure, and then how to analyze. So you have full process. It's full process. So, and I like such type of work. So that's
Mhm.
mean lead me to start with manometry. I started with conventional manometry in 2004. It was at that time there was no high resolution manometry. Then we shifted to do a high resolution manometry.
Very good. Very nice. Very nice. I'm very excited to learn a lot from you today because this is something that I struggle with myself sometimes. But before we touch the catheter or we even consider doing this, let's talk about why do we ever do manometry? Endoscopy and imaging usually in a patient, they look normal. These patients may come with dysphagia, chest discomfort. Manometry answers a functional question usually. Is the esophagus coordinating correctly? And do the sphincters relax when they should? So, from your perspective, in what clinical scenarios should we even consider manometry, and when should we not?
Okay. Actually, we can say that manometry is the only way, it's the only way, or the only tool that we can use to measure or to make diagnostic for the motility of the esophagus. This is
Mhm.
the so far as a medical device, it is the only tool that we can use. And mainly we are using manometry. Let's say we for diagnosing two parts of the esophagus. We have the body of the esophagus, I mean the contraction of the
Mhm.
esophagus, and the outflow of the esophagus, the LES. If there is any like hypertensive LES, or if there is any obstruction in the LES, there is no relaxing for the LES. So we have two parts diagnosing the body of the esophagus, the contractions, and we have the functionality of the LES. And this two concept is described very well in the last Chicago classification number 4. It's
Mhm.
everything it's explained in this. So I highly recommend anyone who want to do manometry, as he has to be so familiar with this classifications. Usually, the cases or the patients that refer to manometry, it's very common that any patient has dysphagia. Let's say dysphagia in general. They have
Mhm.
some swallow disorders. When the patient eating, he feel that the food is stuck in the esophagus. For sure,
Mhm.
the patient, when he will describe the case, he will say that once I eat, I feel that the food is stuck either here in this part or in this part. We have different cases, not the same. And
mm,
he will say the patient that I have to drink water after
mm,
each time. I have to drink water to like it's like to push the food going down. And
mm,
some patients say that we feel that there's some pain during the swallowing. And for sure, we have some patients they have these symptoms for food and
mm,
liquid. Some of them
mm,
only for food, and some of them only for liquid. Also, we have different cases. So we have to ask the patient when you have these symptoms. So the only way to know or make diagnostic for the motility of the esophagus is to do manometry. For
the
sure, we have
manometry.
another
Mm,
tool that can help sometimes in case we have inconclusive uh, uh, reporting to do timed barium swallow. That means also somehow we have to correlate between both of manometry and barium.
barium. Okay. So the manometry, it's not a screening test for reflux or a substitute for endoscopy. It's a targeted thing. It's very important for
Exactly.
everybody who is ever is going to contemplate referring a patient. You must have patient that has dysphagia, that has normal endoscopy. You suspect a motility disorder, whether it's the body of the esophagus or the lower esophageal sphincter, uh, or whether you have a patient that you already know they have a problem and you want to maybe assess them pre-operatively, maybe if they're going to do a fundoplication or something, right? Or if you want to
Yes.
rule out, for example, some motor disease, some connective tissue disorder, something like that, before you label that as functional. So if the clinical question is not clear, doing a manometry will not really help us or the patient. Would you say that is correct?
Yes, that's totally right. Actually, it's very important not to know that, as you said, manometry it is not the procedure that we can do without any questions. The question that you mentioned, there should a
Mm.
question in our mind to let us do manometry. Uh,
Right.
I mean, it's not that any patient he can come and you say, okay, let's do manometry. We can't at all. He has should do like OGD before. We have doing some other investigation. Then we have question mark. By manometry, we will find answer for this question. It's either positive, either negative. And also,
Negative.
as you said, it's very important manometry to be. It's like gold standard manometry before doing any surgery for duplication or any surgery
Mm.
for reflux diseases, we have to do manometry. Why? Because sometimes it's better to keep the patient with GERD rather than doing surgery if there is any disorders in the esophagus.
Right,
That
right, right.
means if there
Mm.
is any solid disorder in the esophagus and we did
Mm.
surgery for reflux, so the case will be much more worse.
Right.
So we
Mm.
shouldn't do any surgery for esophagus unless did before the manometry.
Right. And oh, this is great. This is fantastic. This is like so we're just setting the stage here. I thought like, we talked about this before we started recording that this issue, it's a quite big topic. We thought about covering everything in one episode, but we thought it's not realistic, so we decided to divide this into a series of episodes where we are going to be focusing in the first episode, which is part one today. We're going to focus on what normal is. And next
Yeah.
episode, we're going to discuss what is abnormal manometry. And then in the third episode, we can talk about pH monitoring and impedance. So
Yes.
today is about normal manometry because if you cannot recognize, because you cannot recognize disease if you don't know the baseline. So when you issue a report, let's say you have a patient and you issue a report that says normal esophageal manometry. What should the clinician do with that information? Please send me something like this. What should I do with this information? What does that mean?
If the patient has normal,
Yeah,
you
yeah,
mean?
normal. I send the patient to you and you do the manometry and you say like, you send me back the report. It says it's a normal normal study. Nothing is wrong there. What should I, as a clinician, do with that information? What, like, from for me, it means that I would say that it's probably a functional disorder. I do not need to think about, the organic disorders. So maybe it's just, but from your point of view, what does it mean?
That means is usually if we have many cases like this, so the patient has patients came with they are, as per the explanation of the from the patient themselves, this is the
Mm,
symptoms of the swallow disorders. But actually, when we are doing the manometry, it seems to be normal. That
mm,
means maybe sometimes we have some exaggeration from the patient themselves. They they
mm,
they they try to explain more about the symptoms just to push. That's what I noticed, to push the doctor to find solution for his problem. We have some psychiatric cases that the patient is totally normal, nothing's to do. So,
mm,
so for this reason, it's very, very important to make sure that this is patient, it's normal motility. Because
mm.
once we say that it is normal motility, that means the physician has to look after different things. Yeah, maybe he has to
Right.
do another investigations. He has maybe to think in different way to find
Mm.
the reason behind these symptoms,
Yeah.
maybe
Yeah.
medications or lifestyle, many other things. So we
Perfect.
have
Yeah.
to be very accurate when
Mm,
we to mention in the report that it's normal, it should be
mm,
really normal. If
mm.
it's inconclusive, we have to mention that it is inconclusive.
Right.
And for sure,
Mm,
this behind this many things we have maybe in next episode we have to explain that what the things that we have to consider to make sure that we did the the procedure in the right way, because many
exactly.
things will
Mm,
affect the procedure
mm,
itself. Maybe it will give
mm.
wrong results. Maybe
Right.
some
Right.
artifacts, maybe sometimes the position of the patients will affect the results. So we have to be very accurate in preparing the
Mm,
patient and during
mm.
the procedure and during analyzing.
Right. So we have, like, but this is actually very great. So for everybody who's listening here, it's very important. Like, do we have, is it a confident, normal esophageal manometry or inconclusive? Because if we say we're confident that it's a normal study, then we have ruled out some major disorders such as achalasia, some jackhammer esophagus, like some esophageal spasms, and that redirects us into takes it in a different direction. Is there reflux there? Maybe there's reflux. We need to start thinking about pH monitoring, impedance, stuff like that. And if symptoms fit a functional pattern, and that's when we consider a functional diagnosis. So normal study actively should guide the physician. I would say, if I were to receive this result, a normal study would actively guide me to the next step. It's not like a non-result. Usually, the physicians get disappointed. I've noticed if they get like, oh, it's normal. It doesn't mean it's nothing. It means you need to think, okay, is there something else that you need to do? Or is that the time when you just put your foot on the brakes and you say, like, okay, we have reached a functional diagnosis, so that you redirect therapy in that direction.
Yes.
Yeah. Um,
Yes. Yeah,
so,
you are, this is it's a good point that you raised here, that it's like confident when we say this is the manometry about the results. Actually, with the Chicago classification 4, they covered many things that was not covered in Chicago classification 3. In
mm,
classification 3, there was some points it's inconclusive, and some things may cause like some confusion. In
mm,
classification number 4, they try to cover it, so they have a different algorithm that helps more to give
mm,
conclusive result. But actually, in BH impedance, we may see inconclusive more than manometry. Yes, in because in BH, many things will affect the recording because we are recording for 24 hours. And the
mm,
patient has to press the buttons for the eating, for sleeping, for the symptoms,
mm,
and the understanding of the patient from his side, what is the symptom that he has to press, then make analyzing.
mm,
So many things will affect. So we can in BH impedance we can see that some inconclusive results. But most probably some cases for manometry, it's very clear to be very clear. Let's say, for example, achalasia type 2, most of cases it's very clear. Very clear it's achalasia
Mm.
type 2, no doubt. And
Yeah.
absent contractility, it's also very clear.
Mm.
Usually, what it sometimes may cause confusion, it's like intrabolus pressurization with or distal esophageal spasm.
Mm.
Sometimes because of the when you are make evaluation for the LES and the body of the esophagus, sometimes some criteria it's make confusion between which result that we can have decision based on it. So that what it's added to Chicago classification for that to do some swallow or 10 swallow in supine position and then 5
Mm.
swallow with rapid multiple rapid swallow and challenge drinking challenge in upright position. They added
Mm.
this protocol to overcome the inconclusive result that may have if we did the cases only in supine position.
Right, right, right. Yes, and
So here I highly recommend if someone just started from Chicago classification 4 to read again Chicago classification 3 and to see the difference and to
difference.
understand why we shifted to classification 4.
It's fascinating. Like these guidelines, there's always like guidelines. They're always like they're like a living organism, right? They like always adapt and evolve as we go and as we get more and more evidence to do the
Yes,
things that actually gives us a result that is valuable. And this is where a good segue into my next point here that I'd love to discuss with you is that getting a good value from manometry starts with ordering it for the right patient at the right time. So,
yes,
what ordering mistakes do you see most? Wrong timing, wrong population, or medications that confound the results? What is it that you see most often? Because many patients they are referred to manometries, but they don't never need them. From your
yes,
experience, what is the thing that you see most often, like, recurrent thing that any physician who is listening should actually pay attention to and avoid referring the
yes.
patient for manometry?
Yes. Actually, we have here two cases. It's sometimes it's based on the symptom that the patient has and how explained these symptoms to the physician.
Mm,
If sometimes there is some misexplanation between the patient and the physician, so the physician say, okay, it's now I have to do manometry.
mm,
So the best way to refer to manometry, we have to do scope before. It should be
mm.
100%. We have to do scope before,
Yeah.
then we can refer to manometry.
Mm,
And also for this is the same if we
mm,
are going to do BH and impedance recording. Sometimes it's based on the how long the patient has these symptoms. If
mm,
it is just for short time, it
mm,
means maybe other causes that lead to these symptoms. But if
mm,
it's lasted for long time, that means for sure we have after scope we have to do manometry. Unfortunately, we can say that 85% of the cases we receive it's abnormal. The reason behind that, many patients they start or they trying to adapt the symptom that they have. They think that this is normal symptoms. If they have some difficulty in swallow, they drink water during the meal, they consider this
mm.
is normal. For maybe
Yeah.
5, 6, 8 years, they are doing the same. They say, okay, this is what I am doing since long time.
Yeah.
The patient they don't know that this is abnormal.
Yeah.
And the second point, unfortunately, also that some patients they take time to reach to the gastro or to the motility unit in the hospital. They started from the physician for the general physician, then maybe the internal medicine, then to reach to the gastro.
Yeah.
Maybe they tried at the beginning to have some like medication, lifestyle to change the type of the food.
Mm.
After trying all of these, they referred to manometry. So
Yeah.
most of the cases reached to the motility department is
Mm.
abnormal. And at the
Mm.
same time, we have a lot of cases referred to manometry before doing surgery. The patient has GERD.
Yeah.
So now I'm talking about not the motility. They have patient have GERD and the patient is referred or suggested to do surgery. So they referred
Mm.
to do manometry before doing the surgery. So mainly this is the most of the cases that we have.
That you see. Okay. And then
Yes.
in that case, so let's say that we have a patient where we have done everything that we need to do, and this patient is a good candidate to undergo manometry. So you said before, a lot of these studies are lost in the preparation phase. So what are the non-negotiables for patient preparation to capture a clean, normal study? You've already mentioned a few things here, but if we can go through them one more time quickly, what are the things that are most important in terms of patient preparation if they are a good candidate for manometry in order to get the
Yes.
results that we like?
Yes. The good things for manometry, the preparation, it's much more similar to the preparing patient for the upper scope. The
Mm.
patient has to be fasting, and the things that we have to explain to patient, to explain the patient what is the procedure,
Right.
because let's say 99% of the patient when they came to the room of the motility procedure, the first question, is there any anesthesia?
Mhm.
Why? Because most of them, they think it is scope. It's like the scope.
Mm.
So, in the scope, that means there is no pain.
Yeah,
So this
yeah,
is the thing. This is the first question. If there is anesthesia, we say no. They say, why? It's difficult. How I can tolerate?
yeah.
So, uh, really, 95% of the cases, we explain to the patient the
Mm.
procedure 5 minutes before the procedure.
Yeah,
So he has to be prepared. I mean,
yeah.
to know what is the procedure
Mm.
that to come without any fearing, because sometimes if he's not comfortable, it will affect. He should be very comfortable.
Yeah.
So maybe later on when we explain the steps, how to start when we start the recording or the manometry, the first thing is we have to give some few minutes for the patient to calm down, to be comfortable.
Mm.
Then we start asking patient to swallow. So actually, I believe it's the main challenge, preparing the patient to explain to
Mm.
him exactly
Fine.
what is manometry. It is not scope. It is tube
Mm.
because scope it go through the nose. There is no anesthesia. You have to
Mm.
be awake like to
Yeah,
10, 15 minutes. So I
yeah,
think this is the main thing to
yeah.
consider in preparing the patient.
There are a lot of patients here. This is why one of the main things that we have done in our unit is that we have made sure that we have prepared these like information brochures for patients for each of those procedures that are written in
Yes.
plain, simple language, and it is obligatory for the patient to come to the unit and receive that brochure a couple of weeks in
Yes,
advance
it's
before
perfect.
undergoing the
It's
procedure
very
so that
nice.
they can read it at home so that when they come they have at least an idea about what we're going to do so that we do
Yes.
not I would say not to waste a lot of time in trying to explain to a patient who's already quite nervous so they're not taking a lot of information. So I fully agree
Yes.
with you on
Yes.
this patient preparation and expectations of the patient. And if now
Expectation.
if we jump right into it, so if we try to demystify the test itself, so can you walk us through a standard normal manometry from catheter placement to the swallow protocol?
Yes, let's say I will share my screen with a case. It is for the no, normal patients. I just now just it is very very brief, just to show how it look like, how the recording will look like, and maybe I will mention some points during the explanation about what the point is important during the procedure. So I will share my screen. Is it clear?
Yes, very clear.
Yes. So, first of all, usually doing manometry, it means that we have to do 10 wet swallow. Each swallow it is 5 ml. We have to do at least 10 ml wet. Each swallow is 5 ml. So why we are doing 10 at least and 5 ml? Because the normal values, the
Mm,
reference for we'll see the DCI and the IRB. It's calculated and it's gold standard based on giving patients 10 wet swallow. Each swallow it's 5 ml.
mm,
So this is the first we have to put on our mind that we have to do. What it means, for example, let's say if we started with the patient, we started giving him the swallow, and he's just at the swallow number 5, he can't tolerate. He said,
okay.
I have to stop. So that means the this procedure it's useless.
Okay.
We can't rely on it at all.
And if
Okay?
I pause you for a second here, Basil, and let's just rewind a little bit back. Let's say that the patient is sitting on the bed, and you bring that catheter that you have calibrated, and it's all ready to go. The way you do it, do you usually like put some local anesthesia in the nose, or like some gel on it, or what do you do? How do you insert it?
Yes, good question. Yes, for sure. Easily to explain it, it's like the NG tube. It's like the insertion of NG tube. We have
Mm,
some KY gel, that's all.
mm,
No need to put any anesthesia lubricant because this may affect if we because we after we insert the probes, we will ask the patient to swallow. So
right.
if if you put any anesthesia, it's either it's gel or spray,
Yeah.
it may affect. So it's not
Right.
recommended at all to do it. It's not recommended. Maybe in just very few cases, very rare cases, we
Yeah.
can, but it's not recommended. It's
Okay.
I think it's logic because a patient
Yeah.
has to swallow.
Be able to
So
swallow. And we
yes,
have inserted now. We've inserted this catheter. How do I know how far in I should go?
exactly, yes. So when we start to insert from the nose, at
Mm,
the same time, we ask the patient to drink some water.
mm,
Drinking water, it's help to UES, the upper sphincter, to open, then the
mm.
probe can go through easily.
Right.
Okay? Then
Mm,
we go down. During the insertion, we are monitoring or the on the screen. This is the screen. We are
mm.
monitoring this pressurization here, which is the UES, the upper
Upper.
esophageal sphincter.
Right.
We have to make this we call it also high pressure zone. This is the high pressure zone, the upper
Mm,
one. We have during the insertion, we have to make sure that this upper high pressure zone within these two lines.
right.
There is two lines here. It should be within these two lines. In general, for adult, usually the depth of the probe between like 43, 44, up to 50, 52, 53. It's
Mm,
totally depends sometimes on the how much the patient is tall.
mm,
But this is the average of the
mm,
insertion. During insertion, we have to take care that it is going down smoothly because
mm.
sometimes it's going from the nose, then it's kinking in the throat or in the mouth and going up from the mouth. So I
Yeah.
always, when during the insertion, I always asking the nurse that she is doing the insertion, you have to feel that it is going down smoothly. Always asking it's is if she the nurse she feel that there is
Mm,
any resistance, she has to stop.
yeah.
Don't push forcefully. It should
Mm,
be smoothly, quickly.
mm,
Then I have to make sure that this high pressure zone within these two lines. Okay.
mm,
So
mm.
then I have to fix the probe on the nose. I have to fix by
Mm.
plaster.
Yeah.
Then I ask patient to lay down. All
Yeah.
the insertion I have to do in sitting position because it's
Right.
much more easy.
Right.
Then once it's in, ask patient to laying down.
Right.
The most also, and it's the first important thing that we have to do before start the swallowing. We have to
Mm-hmm.
ask the patient to do deep breath.
Mm-hmm.
Let me check if it is here. I have to see if the deep breath here to show what does it mean. Okay. Deep breath, like this one. You can see this one.
Mm-hmm.
This one, it is deep breath. Why I have to ask the patient to do deep breath? To make sure that the probe in the stomach, okay?
Okay. Okay.
When the patient has doing deep breath, the
Mm-hmm.
pressure in the esophagus will be
Mm-hmm.
decreased and the pressure in
Mm-hmm.
the stomach will increase.
Mm-hmm. Yes. Yes. Yes.
That
Yes.
means it is in the esophagus. We have to do it at the beginning. Okay.
Right.
We have to ask the patient, but this after calming down the patient to be comfortable for like 1 minute. Then we ask
Yeah.
the patient to do the deep breath for 3 times.
Mm-hmm.
Suppose, let's say, if we see that all this line, this is the blue, the dark blue, it's from up to down. There is no
Yeah.
increase here in the
Yeah.
pressure. That means the catheters it's fully in the esophagus. So it could
Okay.
happen because maybe the
Okay.
catheter it's kinking in the
Yeah.
LES. It's not passed.
Yeah.
So we have to make sure before doing the swallow.
Miss Hello.
Let's
Okay.
back to swallow. Then we will do the swallow. We will give the patient in the supine position. We give him 5 ml water. It's normal water.
Mm-hmm.
It should be a temperature room. It's not too cold or neither it's hot because it will affect the motility sometimes if it's cold or hot. Then we
Mm-hmm.
ask the patient to swallow.
Mm-hmm.
This is typical normal swallow. What we will see in the each swallow. In each swallow, we will see this is the high pressure zone, the upper one, which is the upper sphincter,
Mm-hmm.
upper esophageal sphincter. And we have this part, it is the body of the esophagus. And we
Mm-hmm.
have the lower part, which is also, we call it high pressure zone, but this is the LES, it is the lower esophageal sphincter. So we have
Mm-hmm.
to see these three parts in each swallow. Let's see
Right.
from this, once we give the patient the swallow, we can see that here we have, before the swallow, this is what we call its resting pressure.
Yeah.
Once the patient start to swallow, we will see here relaxation in the LES. Here, this
Mm-hmm.
is the relaxation in LES. At the same
Okay.
time,
Okay.
the UES, sorry, this is the relaxation of the UES. At the same time of the relaxing in the UES, there should be relaxing also in the LES.
Okay.
Okay.
Mm-hmm.
Then this is the progression of the swallow.
Mm-hmm.
Then this is the to the LES. Then we call it recovering for the swallow. It will be finished. Okay.
Mm-hmm.
Usually the total swallowing time it's like 5 to 6 to 8 seconds. I mean this is progression from here to here. It takes sometimes
Mm-hmm.
like 5 to 6 swallow. But to
Mm-hmm.
start the next swallow, we have to wait 30 seconds. We have to wait 30 seconds to start to give the patient
The
the
next sip.
next,
Next sip
yes,
of
next swallow.
water. Okay.
Yes,
So
next sip
so
of water.
so if I understand,
Yes.
so basically this a normal study here means like we're looking at the upper lower esophageal sphincter, and what we can say is that they're like gates, and they open and close at certain pressures and according to certain physiology, and they should open and close at the right time.
Mm,
So when you're doing
Yes.
this, um, before we look at the whole like peristaltic wave, let's call it, what do you look for specifically to confirm the relaxation in the lower and the upper esophageal sphincter?
Yes.
You have said like you're looking at that, like let's say that you are mentioning that green part on top with the slightly reddish in the middle. So like for people who do not understand this, probably it's important to say like that the color indicates the pressure. The darker the color, the warmer it
Yes,
is, the
yes, yes,
higher the
yes.
pressure, right?
Yes, that's right.
So
That's totally right. This
yeah.
one, this is the scale of the pressure. It's that good that you asked for this one. This is the scale of the pressure. You can see
Mm,
that it's this is the blue one. It is like almost the zero. It's dark blue. It's like minus. As
mm,
going up to green, yellow. That means more pressure. That's mean
right,
more pressure. For example,
right.
here you can see in the middle, it's like orange or red, that it's high pressure here, which is the
Mm,
normal. Here the
mm,
question we have, if we can ask why the pressure here increased, why in this part, this is normal, but why the pressure increased here in this part, not in this part?
yeah.
The answer, this is the things, it's logic to have. Why? Because as the contraction now it's reached to the LES, know that
Mm,
LES, it's like we can say that it's strong muscle, it's closed.
mm,
So
mm,
we need higher pressure in this part to push, to open, to push
mm,
the food to going down to the stomach. Okay,
right.
so this is the logic things should be to have
Yeah.
here a higher pressure than here, and also we have here what we call like it's a, break. We have break here. This
Mm,
break because we are moving from different type of muscles, the
mm,
smooth and the straight muscles. So we have this break which is normal, but
mm,
normal it should be within range. It should be between 2 and 5 centimeters. It's normal. If the break more than 5 centimeters, maybe we have a type of ineffective motility.
what do you
This
think?
is
Right.
the body of the esophagus as a numbers. Let's say now if we are talking about numbers to or parameters that we have to measure,
Yeah.
we have here this box,
Yeah.
this one. You can see that it's mentioned that this box is DCI, distal contractile integration, this one.
Mm,
Okay. So this one, the box, this one, it's reflect how much the contraction is strong. We
okay.
call it the vigor of the contractility, how much is strong.
Okay. The whole box in there. And
The whole box, yes, this
yeah,
one.
yeah. And is this something that is measured in certain numbers that we need to look at? I mean, for me as a physician looking at this, do I need to do it that way, or do I need to focus on the other things, like, for example, what you mentioned before, this integrated relaxation pressure, for example?
Yes, yes,
Uh,
that's
uh,
perfect.
so if we try to make it,
Actually, we have to focus on both. We have to focus on both. For example, you can
oh,
see, for example, this one, the DCR, it's 1,294. And you can see
mm,
that it's mmHg, S, and centimeters because it's measured. I will
mm,
show you one things here, which I think it will be very to understand very well. So, and this we can understand very well how the contraction will be. So this is in the upper, this is the UES, this is the relaxation, this is the, because you can see, so it's like a mountain, that's like heights.
fantastic.
So when we make the calculation for the DCI, it means we make just mathematics. We have this X and this X, like let's say X, Y, and Z,
Yeah,
and we
yeah.
make multiple all together to get the DCI. That's all.
Mm,
So
mm.
it's we can say that it's we are in DCI. It's a number that reflect how much this is high. If we're talking, it's like mountains. How much it
Mm.
is high. Okay.
So
So
what is
look.
DCI? If you explain to me what does it stand for, DCI, and what should we expect in terms of values here?
Yes, I will just in this case we have to back again.
Mm,
So this one, let's say again, this is the DCI.
mm,
It's now we have to see this the number, the value, which is usually it's mentioned here. This is the DCI. The DCI is we have normal values, which is between 450 up to 5,000 or 8,000, it is normal.
Mm,
From 0 to 100, from 0 to 100, it's filled. Okay?
mm, mm,
It's filled contraction. From 100 to 450, it is
mm.
weak. It's weak
Right,
contraction.
right.
Okay? So in case that the patient has the value it's below 450
Mm,
and we have normal LES, it is
mm.
not the IRB is normal, that means the patient has ineffective motility disorder.
Okay,
Ineffective
okay.
motility disorder. Okay.
Mm,
So in case, for example, in case that the patient has DCI, it's very high, it's like 8,000, though maybe we have spasm or we have nutcracker,
mm.
jackhammer. Okay, it's too much.
Okay.
So this is the
And
so this is the DCI. But here just that we saw as this number, based
mm,
on this number, we will judge if it is normal or abnormal in effective motility. So we have to make sure that this is the border, it is in the right places. I mean,
mm.
suppose if it is like this, for example, you can see the value decreased.
Right,
So
right,
to make
right,
sure
right.
that this is box in the right position. Maybe later on we can make one episode to talk about this points.
So how does DCI connect with a lot of people? Many, I think, Muslim gastroenterologists are familiar with DCI and also IRP, or integrated relaxation pressure.
Yes.
So, because quite often it's one of the first things in the report you look at is IRP, which is commonly, what is it, less than 15 millimeters of mercury, right?
Yes.
Uh,
IRB, yes, we see this. The IRB, this one, this box, this is the IRB,
mhm,
integrated relaxation pressure. And the IRB, it started from the same point when the UES relaxation starts. Should be at the
right,
same column.
right,
It's like this.
right.
Okay?
Yeah. So this is what we see. Usually we see, like, and the lower esophageal sphincter, we should align it with that brief relaxation at the upper esophageal
Yes.
sphincter, right? And
Yes.
and and if both of them, let's say, behave well, then we have cleared two major issues here. That is normal. If we see
Yes.
relaxation, that which is that brief, let's say, that empty space in the top,
Okay. This
part,
one, yes.
right? Yeah, that you're, yeah, exactly. And if this is, if
This
this
one.
is aligned, yes, exactly. And this is, if we align this with the same spot around the lower esophageal sphincter, and we have an IRP that is going to end up on under like 15, or the 15, 20 is the borderline.
It's
Uh,
20 borderline, yes.
yeah, then we say, then we can exclude a disorder of the sphincter itself. Can we say so?
It's this is the one of the criteria. We have another criteria we have to see.
Okay, what is the
Yes,
other
this one the criteria.
criteria? What is the other
Okay, right.
criteria?
Exactly. See, this is the LES. As you said, that should be at the same time relaxing between the UES and LES.
Right.
Okay, at the same time. So the IRB, it's very, very important. It's very critical to make uh, evaluation for many other things.
Mm,
IRB should be below 20.
mm,
20, it's the upper normal value.
mm,
But sometimes in some cases, maybe it could be like 21, 22.
mm,
So if we have such cases, 21, 22, we have to
mm,
correlate with the symptoms. I mean, if the symptom of the patient is totally normal, the scope is normal, and we found that this is the IRB, it's like 21, 22. So
mm,
we can say that it's normal, it's still within the
mm.
borderline.
Right.
Because even before they considering the 20, it's the the normal, it was 15.
Mm,
there was some standard 15. They are some saying it's 20 because
Mm.
uh, we have two type of manometry. We have water perfusion and we have solid state. So it is actually it's not the same normal values. It's
Mm.
one of it was 15 and was 20. Then they decided in last classification that to consider it's 20.
Yeah.
So if the IRB it is abnormal, let's say abnormal, like 25, 30, okay?
Mm. Mm.
And there is contraction, there is peristalsis here.
Right.
That means we have outlet,
Mm.
outflow obstruction. So that means we have obstruction in the LES. So that means the
Mhm.
LES it's not relaxing.
Right.
In this case, if there is obstruction here, most of the cases we will find that there is what we called it intrabolus pressurization. Intrabolus pressurization, it means like we have pressure here, below here. In this area, you will have a lot of pressure.
Mm.
If there is intrabolus pressurization, this means that we have obstruction here.
Mm.
And we have to know that if the patient has this obstruction for a long time, 3, 4, 5 years, you
Mm.
can imagine that the esophagus starts, that usually the normal things, LS has to relax, then the
Yeah.
food going down.
Yeah.
Say if day by day, month by month, year by year, the LS
Mm.
it's not relaxing. That means there is more pressure on the body of the esophagus.
Right.
That means
And this.
the
Mm.
normal esophagus will be like this, like cylinder, but
Right.
because of the always there is pressure inside the esophagus, so the esophagus will start to dilate it.
Exactly. This is what they call
But the
bird beak
LES it was
esophagus. Yeah. Mm.
exactly,
Mm.
exactly. So, but at the same time, still LES closed, and
Right.
the esophagus was like this. It become like this, dilated,
Yeah. Yes. Yes.
and you can see
And
it's easy
mm.
by scope. When you're going by scope, you
Yeah.
can see a dilated esophagus and very tight LES. So that means it is one type of achalasia.
Yeah. And we usually see other things as well. Like sometimes if it goes too far, too long, you get this thing that's called sigmoid looking esophagus. It looks almost like a sigmoid colon.
Yeah.
You start finding like sometimes food debris. You may find quite a lot of mucus or like fluid hanging around in the
Yes,
esophagus.
yes,
And at the same time, you
that's
can
right.
see that the esophagus becomes quite fibrotic, quite hard.
Exactly.
Uh,
Yes.
and the longer it goes, the more difficult even treatment becomes because of the fibrosis
Yes, exactly.
and
So
it
this is
lands
I
in the
think this is
muscle.
the type that you can see. It usually make type 1, achalasia type 1 or 2 or 3. It depends.
Depends
Okay.
on. Mhm. Mhm.
Yes. But it's the notes that I have to just to focus on it. That again, if there is a high pressure in the LES, IRB, it's abnormal, and there is like you can say that it's outflow obstruction, and there is peristalsis.
Mm.
Here we have to do we have to move to the second maneuver, which is to give the patients swallow in the upright position. Here we
Mm.
are moving to Chicago classification 4. In Chicago
Mm.
classification 3, once the RRB is abnormal and there is peristalsis, that means that there
Mm.
we have obstruction. But in Chicago classification 4, they say no. Before we make conclusive result, if we
Mm.
are suspected that there is outflow obstruction, we have to move to the maneuver in the upright position. So in
Right.
the supine position, we will give the patient 10 swallow, 10 wet swallow, 5 ml. In the upright position, we will give the patient 5 wet swallow, each one 5 ml, and we
Right.
will make what we call it the drinking or drink challenge. The patient will drink continuously 200 ml, and we will do multiple rapid swallow. We will give patients for 2 ml five
Mm.
times like 2, 3 seconds between each one.
Okay.
Okay.
Yeah.
Then, if we did all these things,
Mm-hmm.
upright position, supine position, and still there is high pressure in LES,
Mm-hmm.
abnormal, we can say that it's conclusive that it's outflow obstruction.
Mm. Okay.
Okay.
Okay. Oh, very interesting.
So here, this is
Mm,
the
mm,
thing, the
mm,
good things
mm.
from Chicago classification 4. But for achilles, as I said, it's more clear. If the
Mm,
IRB it's abnormal,
mm.
maybe in next episode we will present how the achilles look like. And
Yeah.
if the IRB it's abnormal and if there is no peristalsis,
Mm.
that means it's maybe achalasia type 1. If there
Okay.
is pressurization, what we call it pan-esophageal pressurization, that means it's achalasia type 2. If there is spasm,
Mm.
that means it's achalasia type 3. Okay?
Very good. And this is something I will touch
Oh,
up on in the next episode. But if we can look now at this figure that you showed, if we can see like the swallows consecutively, can you show us a figure what they look
yes.
like one after the other so that anybody who's watching would see what the
Yes.
normal look like and if you can comment quickly on
Yes.
that.
Yes.
Uh,
Okay. Let's see. This is swallow. This is the first swallow. It is normal. We can see here the DCI. It's normal. The RRB.
mm,
It's normal. Then the next swallow. It's normal also. This is the relaxation. UAS, LES. It's normal. IRB. Then move to the next. You can see it's almost the same. Everything normal. Normal.
Of all these values you look at, for somebody who's not familiar with this, me and you, we work with this, we have an idea. For somebody who doesn't work with this and doesn't and is not as familiar, out of all of these values that you're getting UES values, LES values, and esophagus values. And so
Yes. Yes.
which ones would you recommend people to look at out of these and to be more get comfortable with?
Yes, exactly. The most important is IRB, this
Mm,
one, this
mm,
IRB. This is the most
mm,
important. This here IRB, for example, 4, because
mm.
based on IRB, I make judgment on the outflow
Mm,
obstruction,
mm,
and IRB it's the first criteria of the achalasia. So this is the first
uh,
one, and
mm,
also the DCI.
mm,
This one, the DCI, this is the box, this box.
yeah,
Because based on this one, I can judge also if it is normal contraction or ineffective
mm,
or failed or absent. So this is the DCI. Also, we have here, we didn't mention before, but this is the distal latency.
mm,
Distal latency, this one, this line, this, you can see that this, you can see here, this is the progression of the contraction. It's coming like this.
mm,
Then it's may more slow. Oh, sorry, let's see
yeah,
this more clear. You can see it's like this.
and then
Then
slows down.
here, at this point, it started
Mm,
to in different inclination.
right, right, right.
Okay.
Yeah,
And why this happened? Why this happened? Why this is the we have a speed here and we have different speed here because here we are more close to the
mm,
LES.
okay. And what should this
Here because
value
we are
be? What should this value be? The still latency
okay.
and
The
sync.
value should be above 4.5. The value should be above
Mm,
4.5.
okay, okay.
Let's
And
see
is
here. This
there?
is the distal latency 0.1. And this is the inclination between this the vertical line. Suppose we have virtual vertical line here and this point. This point, you can see this contractile deceleration point.
Yeah,
You can see that this the
mm,
position, the
yeah,
distal latency changed. You can see
right. Yeah, yeah,
changed. Okay. So if it is below 4.5, what does it mean? Suppose it is here.
yeah,
That means it's like the solo in this direction.
right.
That means it is very quick.
Yeah,
That means it's very quick. And that means there is spasm. It will be there is be spasm here because again, it's not like this, the inclination, but it will be
Yeah.
down. So that means there is spasm here. So distal latency is the criteria for the distal esophageal spasm.
Okay. Okay. So that's another value that people should keep
Exactly.
in
Yes.
mind when they look at this. So
Yes.
now
If
we
you
have so we have yeah, sorry, go
so
ahead.
now we have IRB,
Hmm.
we have DCI, and we
Hmm.
have distal latency DL.
Yeah, very
Okay.
good.
So this is
Very
the
yeah.
things.
So these are like is it out of the are these would you say that these are the three most important values that we should be aware of and we should look pay attention to or are there other values that we should be paying attention and focusing on that may change the diagnosis altogether.
Actually, all the diagnoses that in the manometry will be
Mm.
based on these three:
Based on these three.
IRB, yes,
Yes.
IRB, DCI, and
And the latency.
intelligence.
Mm.
And actually, to be honest with you, IRB is the most important. The most
Mm.
important because IRB, based on IRB, I have to categorize the achalasia.
Mm.
And
Very good.
once I say that it is achalasia, that means we have to refer the patient to procedure. So have
Right.
to be very accurate, to be very accurate and confident about that this is the RB, it's considered correctly
Mm.
before I give the final result.
Right. 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 And this is what we are talking about before recording about like this is where like the use of endoflip has come into practice where we can measure like the distance stability index and the diameter and like
Yes,
pre-procedure and peri-procedurally as well to ensure that our results or like our uh whatever it is we did, whether it's a myotomy or as a poem or
yes,
anything else, has had any proper effect on the
right,
patient. Yeah.
right.
Um, in
So
terms
if you
of
just
art, yeah.
okay,
Sorry.
just quickly, if you want, just so this one. Okay. This is the swallows. Thus, let's reach to the averaging this 8. For example, let's see this one. If you look for the DCI, it's 283. That means it's weak swallow. Why it's weak?
Mm,
Because it's below 450.
mm,
Okay. But for sure, our judgment it will be on the averaging of the 10 swallows. It's not based on one
yeah.
swallow. So we
Yeah.
have to
Yeah.
continue to see all the swallows. This is the
Mm,
10, and this is the average. This is the average of 20 swallow. You can see it is normal one.
right.
So
Right. Right.
IRB it's normal, and the DCI is normal. This latency is normal. So this is typical normal case.
Right. And now, if
Right.
we talk about like the most important artifacts that can make a normal esophagus look abnormal, you said like we try to like we mitigate a lot of this now in Chicago 4 by doing like this supine and the sitting up swallows,
Yes.
right? And you
Yes.
said before to me, I remember it's very important that either the technician who knows this or a physician is in the room while this is being done, so that you don't get double swallows or air swallows or hiccups and
Yes.
whatever. Yeah.
Yes. Okay.
So if you say the most
Let's.
important artifact is short, like the things that we should always pay attention to and how we can mitigate them, how can we avoid them?
Okay. Let's say, for example, this one you can see here there is pressurization.
Mm,
Maybe if anyone he who is not familiar with the manometry and he just know that the achalasia type 2 it's should be like pressurization from the
mm,
UES. This is pressurization from UES from the upper to the down.
mm.
So he'll
Yeah.
say this is the achalasia. No. Why?
Mm,
Because here we don't have relaxation at all.
yeah.
Okay. And also we can see that there is a down, there is LES. So for example, this one, it's coughing.
Mm,
Okay. This one, it is coughing. This is one of the things. And there is one other thing, it's artifacts we have to take care and to avoid. It's when we ask the patient to swallow, to make sure that there is 30 seconds between each two swallow. For example,
Right.
this one, let's say this one, the patient he started to swallow here, and this is the progression of the swallow, and the patient he swallowed again. So
Right.
this is the second swallow. And you can
Yeah.
see here the first swallow, it's not complete.
Mm.
Why? Because the patient he started the second swallow. So
Right.
as you can see, this one it's not recorded. I didn't mark it as a swallow.
Right.
Why? Because it's not
Right.
complete. If the patient
Right.
start to swallow, and if the patient swallow the second one, sip, or maybe it's dry swallow. It's not always wet swallow. Maybe he's just doing dry swallow.
Mm.
So the second swallow make inhibition for the first one. So maybe
Mm.
this one, first one, it look like ineffective.
Right.
Okay, it should look like ineffective, which is wrong. So
Yeah.
we have
We
to
just
take
swallowed again.
to
Yeah.
to see that there is 30 seconds between
Mm.
each swallow to avoid that the swallow is incomplete.
Mm.
Okay, and my recommendation also that when doing swallows, we have to take like not only 10, we can take like 12 swallows because
Mm.
sometimes if we feel that swallow it is not correct,
Mm.
we can delete it.
Mm.
We can
Remove
not
it. Yeah.
consider it in the
Mm.
averaging, so we can move
Right.
to the
Mm.
second one.
Right.
Yes, this is the mainly things artifacts. Yes,
So I would say, like, in terms of prevention, coaching the patient is important about how we're going to do this.
yes, it's
Spacing
very
the
important.
swallows,
Yes,
spacing the
yes, yes,
swallows, the 30
yes,
seconds. And maybe if the catheter migrates, maybe we need to reseat it if needed. And
yes,
if a swallow is like contaminated, if it's wrong, we delete it
yes,
and repeat it. We do not let that artifact define the results of the study because they may have some severe clinical consequences for the patient, right? If you deem that
yes.
the patient has a chalasia but they don't, and they end up doing something that they don't need, it is definitely not something that we want to uh, offer to our patients unless it's correct. So
Yes,
it's very important to actually pay attention to the whole procedure. And really, the
yes.
whole procedure shouldn't take too long if you know what you're doing, right? If you're doing it the right
Usually,
way.
yes, yes. Usually, if the position is very correct and the patient is cooperative, we can say that it's 10 minutes. That's all.
Yeah,
It's 10
exactly.
minutes only.
Yeah.
Yes, yes.
So if we have now like that, I have like kind of written down a template for what a normal manometry report should look like, and you're the expert in this. If you were to receive this report, let's say from me referring a patient to you, would you say is it's okay or not? So I'm going to read it out to you, and you tell me what you think about this. Given the what we have been talking about now, I've been making some notes. Uh, what I would write in the report that the patient was compliant with the pre-procedural instructions. Technically, the procedure had acceptable performance. We document the LES baseline and relaxation with what the IRP is, and then we describe the peristalsis and the timing, and then we add the latency and the DCI as you said, and then we end with a clear summary that this it meets the criteria for normal motility under the Chicago 4.0. Is this a correct report, or is there anything missing from that?
Uh, Actually, I believe this is the totally it's correct. What is you mean the reporting should be mentioned, but I highly recommend that the one who is doing the manometry should be dedicated for manometry. He needs
mm,
to be expert in doing manometry.
mm,
Uh, if this is the case, that the technician who did the manometry, he is professional, so I can totally rely on his reporting. I mean the
mm,
values you mentioned, IRB, the DCI,
mm,
everything.
mm,
But
mm,
if I am not sure that the one who
mm,
did the manometry is professional, actually
mm.
I can't rely. I can't rely
You
on the
can.
numbers because
Yeah.
something sometimes maybe mix. Maybe next time we'll especially in the ineffective motility or chalasia, I will show you how
Mm,
sometimes the positioning of the DCI box or the ARP, how much it will how may affect these
mm,
numbers. So if I
mm,
am just reading the numbers, I am not sure that this is the DCI box. It's placed in the right position. The ARP box, that one, that one,
mm,
it's
mm,
it's in the right position. Okay.
mm,
But
mm.
if I am sure that the technician who did the recording and the reporting, so I can relay on this. Otherwise, I don't recommend to relay. And the best,
Okay.
the best scenario that the doctor who doing the treatment and the follow-up to attend the case. This is the best scenario. But
This
it's
is the
not
best
always
scenario.
possible because you
Yeah.
know that most of the
Mm.
doctors, they are very busy in doing scope and many other things. So it's not easy to attend all the cases because sometimes it take long time. By the way, you know that manometry takes sometimes longer than the scope.
Yeah,
I
of
mean,
course, especially
preparing
if it's
the
not done the
patient,
right way.
insertion, and everything, and explaining for the patient. You know, in the scope, the patient is sedated, just putting the scope, maybe 5, 6 minutes. If it is just diagnostic, I mean, there is no
Mm.
procedure, not polyp, nothings. It will be easy.
Mm. Okay. And now if I were to leave, let's say our colleagues with the, like, let's say this one, like the final checklist for a normal manometry. Like these are the things that I've learned today, like now from what you have been saying, and you have been very nicely showing us. Um, so there's like four things that I'm actually thinking about right now. So the first one would be um, you have IRP in range with a clear relaxation window.
Yes,
That's one
up
thing.
to, yes, IRB.
The second thing would be
This one.
predominantly effective peristalsis without premature contractions.
Exact, which is the DCI. It's reflected by the DCI.
Exactly. And then
Okay.
we have no pan-esophageal pressurization,
Yes. Yes.
which we will touch upon next time when we show that, when we look at
Yes.
achalasia and stuff like that.
Yes.
And a clean protocol, well coached, minimal artifacts. And those are
Yes.
true, then and we know, as you said, they're expert at doing this or like doing this with an expert and learning to become
Yes.
good at it.
Yes.
Then if
Exactly.
those
Yes.
conditions are true, then we're looking at a reassuring normal manometry. Is that fair to say?
Yes. This is totally right. And you know that always you have to put in our mind that based on the report of manometry, surgery decision will be uh, made by the surgeon. So it's we I mean we shouldn't do it in quickly or in hurry. We
Mm,
have to do it very carefully because if we did it, we are not sure about the results. That means the decision from the surgeon will be based or rely on wrong things. So maybe the consequences of this will be worse for the patient.
exactly. Okay, this was great. So we thought we are gonna be doing a 30-minute quick walkthrough here, but as you can see, this is not an easy thing.
Exactly.
You work with this, I work with this, and we still like sometimes quite difficult to break it down into those small like steps and concepts that anyone should follow. So If somebody wants to read about this to learn more, would you recommend people to go and just read the Chicago 4 criteria, or should we maybe that person should go back and read the physiology maybe of the esophagus and the
Exactly. Yes, yes.
swallow disorders before
Totally.
reading the
Yes,
guidelines?
exactly.
Right?
Exactly. First of all, you
Mm,
have to read carefully about the physiology of the
mm,
esophagus, and the physiology and the motility,
mm,
everything. Then we'll start to understand more about the protocols. Because
right.
if we don't have good and deep background about the physiology of the swallow, I mean,
Mm,
so we'll not be able to understand very well
mm,
the protocols. Then, if the background it's very solid base, that we can move to read and understand the protocol. And by the
right.
way, even
Mm,
for the Chicago classification 4.0, it's very easy, it's very clear, but there is a lot of studies and literatures followed after the releasing
mm,
of this classification. They have
mm,
some notes. They have some people, some doctors. They discuss some cases. It's not covered by Chicago classification.
mm.
You can find many studies.
Resources online,
But
yeah.
this Chicago classification. It's guidelines. It's very nice guidelines. It help a lot.
Mm. Now, right now, I don't know this from the top of my head. I'll probably look it up before for our next meeting. I'm pretty sure artificial intelligence is going to come into this realm of analyzing this stuff for us, and even figuring
Yes.
out which swallows are ineffective and what is an artifact and what is not. And
Yes.
it's
Sure.
going to make our job probably much easier, and like kind of upload that time and energy consuming effort from the
Yes.
physician or the technician to actually read through
Right.
these
Right. Maybe.
investigations.
Yes. Maybe in future the AI will help more
I
to
will look this up for next time to see if there's something. I'm pretty sure somebody has looked into this already, but I don't know how far we've come because, and I feel this is the future. Like, we want to make things more easier for everybody, more straightforward, avoid bias, avoid having interference or
yes.
from different factors, but also this should not this should not make us order these tests for patients that do not need it. This is the, I
Sure.
think, this is the other aspect of that, so that we said, oh, we can just put in AI and it will read it for us. But then we're just
Yes,
posing
that's right.
patients to things they don't
You know,
need to do, right? Mm.
it means that at the end the doctor is the leader. Even there is
Mm.
AI, but
Mm.
still the physician himself is the leader of this procedure.
Yeah, very nice, Basit. Thank you very much for your time.
Thank you very
This
much
was
for this
this
discussion, Dr. Samet. Thank you very
this was
much.
wonderful. Thank you, and we will be speaking again definitely soon.
Sure, sure,
Okay. Thank you very
sure.
much.
Thank you,
Have a
Doctor.
good one.
Thank you.
Bye bye.
Thank
Bye
you.
bye.